In this lesson, we will discuss the role and responsibilities of the clinicians. The objectives for this lesson are to identify the roles of each discipline when using this evidence-based model of care, and then to differentiate between what's usually done with traditional care and when this model is used, and then to examine what each clinician does with a participant that's different from my choice care. Here's an overview of the techniques the social worker, nurse, and OT will use. You'll conduct a focused assessment and then assess the participant's readiness for change. Together with the participant, you'll build a person-centered service plan based on the desires and needs of the participant, using problem-solving or brainstorming with the participant. Then using evidence-based techniques, care is provided. For example, this will include use of the motivational interviewing and cognitive behavioral therapy, or using role modeling to build a relationship and self-efficacy. Here's our first checkpoint. Clinician care is focused on the participant's physical function goals so that the person and the environment fit. The answer to this is true. Care is focused on the physical function goals to fit the person and the environment. So here are some qualities of the clinicians when this evidence-based model of care is used. It's flexible, both with scheduling and process. It's non-judgmental, so there's congruency among emotions. You're a good listener and you talk less. And you observe the livability and fit of the environment for the participant. You're team-oriented. You communicate together with the team and their participant and family and caregivers. You're also optimistic, like a cheerleader, and a facilitator. But you're not a magician. You can't fix all the problems. So here's how the clinicians act differently with this evidence-based model of care compared to the My Choice model of care. You listen more intently to the participant's desires and needs, and then support and allow the participant to use problem solving and brainstorming to select the person-centered service plan strategies to meet those desires and needs, with particular focus and targeting on the participant's physical function goals so that the person and the environment fit. This includes focusing on ADLs and IADLs by improving balance and strength, pain reduction, depression management, and effective communication with the providers, in addition to a few other things. With consistent and purposeful interdisciplinary coordination that's focused on the participant's desires and needs to enact a plan. Here's another checkpoint. The difference in care includes listening to participants' needs and allowing the participant to select the person-centered service plan strategies using problem solving and brainstorming. This is true. The key here is deeply and intentionally listening to the person's needs and desires. So here's an overview of social worker tasks and actions. The National Association of Social Workers states the role of a social worker is to conduct an assessment and help participants and families understand particular illnesses and to work through emotions of a diagnosis, and to provide counseling about decisions that need to be made, and to use care management skills to help participants and families address and resolve the social, financial, and psychological problems related to their health condition. Medical social workers play a vital role in the care team. After a participant is enrolled, a social worker may conduct an assessment to help determine needs and identify limitations, barriers, or safety issues. They could educate a participant and their family or caregivers regarding community resources and supports, and assist with long-range planning, advanced care planning directives, and overall care, focused on emotional adjustment to life changes, crisis intervention, counseling with lifestyle changes, and teaching regarding coping with loss or change. In the My Choice program, a social worker applies the knowledge of human development and behavior, social, and economic cultural systems. They use knowledge to assist the participant and family to improve or restore capacity for social functioning. This is done through counseling to meet the psychosocial needs of the individual, active participation in problem solving with individuals and family members, collaboration with healthcare professionals and other providers to assist the participant to understand and support the social and emotional needs and problems experienced by individuals and their families, or advocacy, supporting the participant within healthcare systems, or referral to community-based and specialized services, and development of social work counseling plans of treatment, or assisting providers of services and family members to understand and implement activities relating to the plan of treatment. In this evidence-based model of care, the social worker utilizes the techniques and approaches within these lessons, like using the social ecological model for the person-environment fit, focusing on building self-efficacy and using motivational interviewing. As such, the social worker provides the person fit within the environment perspective, recognizing the participant cannot be understood apart from the multifaceted context of the environment. You conduct the assessment, including depression-focused assessment if needed, and intervene on psychological and social aspects of participant behavior. The social worker is an expert in helping a participant navigate complex health and social service systems. Several case studies will be provided from the pilot project to help you more deeply understand. And here's the overview of RN tasks and responsibilities. The Michigan Public Health Code states RNs provide a systematic application of substantial specialized knowledge and skills derived from the biological, physical, and behavioral sciences. RNs provide care, treatment, counsel, and health teaching of individuals who are experiencing changes in the normal health processes, or for those who require assistance in the maintenance of health and the prevention or management of illness, injury, or death. The American Nurses Association states the role of an RN is to perform physical exams and health histories, provide health promotion, counseling, and education, administer medications, wound care, and numerous other personalized interventions, interpret participant information and make critical decisions about needed actions, or coordinate care in collaboration with a wide array of healthcare professionals, or conduct research in support of improved practice and participant outcomes. In the My Choice program, an RN conducts the RN portion of the IHC and contributes to the person-centered service plan. However, there are 11 variations in care models provided across the 20 waiver sites in the state of Michigan. For example, in some instances, half the RNs coordinate care, and in others, it's the social workers. In some waiver sites, RNs provide direct hands-on care, while in others, they do not. And some waiver sites have 24 on-call service available, while others do not. And as far as we know, none of the waiver sites conduct medication review to detect adverse or contraindicated medications within participants' medication lists. In this evidence-based model of care, the RN will provide a person fit within the environment perspective, recognizing the participant cannot be understood apart from their environment, and then using the evidence-based approaches, perform the role, such as assessing for readiness for change, or using motivational interviewing to build self-efficacy, and also assessing and intervening using evidence-based strategies to reduce pain, improve balance and strength, or improve communication with providers. And also, the RNs will be using an app for medication review and management, and acting as a role model for participants on how to select strategies to self-manage, problem solve, and brainstorm when the RN is not in the home. And here's the overview of OT tasks and actions. The American Occupational Therapy Association states the role of OT is the therapeutic use of everyday life activities with individuals or groups for the purpose of participation in roles and situations at home, work, or in the community. To provide OT for the purpose of promoting health and wellness to those who have or are at risk for developing illness, injury, disease, disorder, conditions, impairments, or disability, or activity limitations or restrictions. And finally, to address the physical, cognitive, psychosocial, sensory, or other aspects of performance in a variety of contexts, to support engagement in everyday life activities that affect health, well-being, and quality of life. In general, an OT role includes the primary goal to enable people to participate in the activities of everyday life like ADLs and IDLs, or helping participants regain or enhance their daily lives after specific events such as a hip replacement or stroke. Also, assessing and modifying the participants' home and community environment to improve their safety and independence, and prescribing and educating participants in the use of adaptive equipment to assist with function. Here's another checkpoint. True or false? The role of the OT is to observe, do a home tour, and to teach practical and useful information to support independence. The correct answer is true. The OT role is to observe and to teach practical and useful information to support independence. So the role of the OT in my choice is to provide services that are covered under so historically, OT services were covered in my choice contract for years. However, few home visits were ever conducted, and fewer my choice sites had an OT on contract or employed one. We think the reason this occurred is that because OT services were covered under skilled home health care or in outpatient or inpatient rehabilitation. So in sum, my choice program rarely utilized OT services. So the OT role in this evidence-based model of care includes the following. The participant will be assessed for the environmental fit with their abilities within their ADLs and IDLs. This will include observation of bathing, walking, getting up out of a chair, cooking, in addition to a home tour to assess how the individual gets around in their environment. The OT will provide practical and useful information to support independence. They'll teach energy conservation techniques during ADLs and IDLs, or ways to live in the home environment, or fall prevention and how to get up after a fall. They'll demonstrate how to get up after a fall and rearrange the environment to prevent injury and/or conserve energy. They'll strategically select use of home modifications and assistive devices within what's covered in the Medicaid program that help the person fit in the environment, and they will refer to a PT and skilled care if needed. In my opinion, after working with the evidence-based model of care for over a decade, I have found the following. The difference I see between the evidence-based model of care and the current My Choice program is that the clinicians are more deeply listening to participants' wants and desires and enacting upon those desires within the person-centered service plan. I'm a diploma nurse, and I was trained to be more directive with patients, or to basically tell them what to do. So for most of my career, I was telling patients when to take their medication, how to change their diet or exercise program, and I wasn't listening. Through use of this evidence-based program, I changed. I now listen better to the desires and wants and needs of the participants and honor the choice the person has elected to improve their life, or they sometimes choose not to do an improvement. It's their life, and we cannot live it for them. We can only help them live the life they choose. This has been difficult as I had some bad habits to break. I try every day to listen better and honor the choice of the person. Here's an example of an evidence-based model of care use that we had experienced during our prior pilot project. Prior to receiving this model of care, the participant had been in the My Choice program for over 8 years. This was a 69-year-old female who lived alone in a trailer. She had a history of Parkinson's disease, neuropathy, diabetes, depression, anxiety, dementia, arthritis, peripheral vascular disease, TIAs, urinary incontinence, and chronic pain. On assessment, she had assistance with outside caregivers 7 days a week for dressing, bathing, and housekeeping. Her conditions changes daily regarding her ADL and IADL ability and her independence. Her goals were to improve function, her ability to eat, reduce her falls, and improve her mood. So this became the focus of her person-centered service plan. It was resources to manage independently, like a folder to take to the PCP to help her organize her thoughts for an appointment, and assistive devices for fall prevention, improving her ADL and IDL tasks, and ultimately independence, mood improvement, and the ability to self-feed so that she could have dignity. So you're probably thinking right now, most of these could have been addressed in the My Choice program, but notably, they had not been for over 8 years. The evidence-based model of care for the clinicians, in this case, had very specific use of the techniques, which are highlighted in red. For the assessment the clinicians completed, that they found the participant's situation and home environment by asking and listening to the desire of the person and evaluating her readiness to change, which is all participant-driven rather than clinician-driven. Then to develop the person-centered plan of care, the team and the participant jointly problem-solved. Using interdisciplinary collaboration, they agreed upon a plan, understanding where the participant was coming from, what their life experiences were through reflecting on the culturally relevant and customized tailored care that she desired. Then the strategies were co-designed and selected among the team and the participant, with active engagement from each discipline and the participant. The social worker focused on improving socialization through additional communication with others, while the OT focused on bed mobility, reducing the fear of falling in the bathroom by having a commode placed over the toilet to raise the height, and obtaining weighted silverware so that the person could feed herself, and strength building, walking to the mailbox assisted and doing exercises. While the RN focused on fall prevention, helping her get up slowly and using a walker for transfer, and also medication review and management and education, helping her maintain a log for her PCP visits so that she could have more effective pain medication, prescription, and use. This was a highly satisfied care recipient who used all 3 disciplines and had additional home visits to improve her quality of life. Here's what she stated. She was sad that care ended and wished it was longer. Care was very helpful. The visits were helpful for her everyday life. I liked the information. It was very helpful. I keep it so I can reread it when necessary. I'm now able to go out into the community and enjoy lunch, feeding myself, and my dignity was restored. She was very highly satisfied, and the clinicians were proud with the changes they made in her life. In summary, use of this evidence-based model of care that is person-centered, self-directed way of caring for My Choice participants helps to better identify their desires and needs and improve their quality of life. When care is focused on the desire of the participant, this is what occurs. This case provided a wonderful example of what, even though the individual had been cared for in the My Choice program for years, that this approach truly made a difference in her life. There'll be additional lessons to more deeply understand the role of each discipline in this care model. Thank you.